Hello, good evening. Today we will be discussing about the another component of the acute coronary syndrome, which is non-ST elevation MI. Acute coronary syndrome has got three components. One is unstable angina, second one is non-ST elevation MI, and the third one is the ST elevation MI. Non-ST elevation MI was known in the past as the subendocardial MI. The major difference between unstable angina and the non-ST elevation MI is that both of these have the reduction in the blood supply to the muscle of the heart. But in case of the non-ST elevation MI, there is another added concept of MI, myocardial infarction. There is death of the cardiac muscles. There was no dying cardiac muscles in cases of the unstable angina, but there was a reduction in the blood supply to the muscle of heart. Here, in cases of the non-ST elevation MI, there is a decreased blood supply to the muscle of the heart, but there is also the damage to the cardiac muscles. Okay. When we talk about the risk factor which cause the formation of the thrombus in coronary arteries, they are same as these were in the patients of the unstable angina. There are two types of the risk factor. One is a non-modifiable risk factor and one is modifiable risk factor. Non-modifiable risk factors are those which cannot be changed by any means. There are three kinds of non-modifiable risk factor. One is the gender, then age, and third one is the family history. Being male, when we talk about the gender, being male puts you at a higher risk of having acute coronary syndrome. Females, when they come into the postmenopausal stage of their lives, then they become as vulnerable as male to develop these problems of acute coronary syndrome. But before being postmenopausal, they have a protection from their hormones, and males are more actually prone to have acute coronary syndrome as compared to premenopausal women. Second is the age. As we age, we become more susceptible to develop acute coronary syndrome. And the third one is the family history. Family history is a very important when we talk about the acute coronary syndrome or non-ST elevation MI. Those patients who have got a very strong family history of acute coronary syndrome or heart attack, they are more vulnerable to develop MI and angina and acute coronary syndrome. When we say a strong family history, what we mean by that? When there is a family who has got their members developing acute coronary syndrome at a relatively earlier age. For example, most of the members, they develop ischemic heart disease at an age after 40 and during 55 years. Then it gives a very strong family history of having MI. So these three are the non-modifiable risk factor which you cannot change. You cannot change no matter what: age, gender, and family history. Then there are certain risk factor which can be modified, which can be taken care of. These are known as the modifiable risk factor. On the very top of that list lies the diabetes mellitus, hypertension, smoking, hypercholesterolemia, and sedentary lifestyle, obesity, and type A are the stressful lifestyle or stressful personality. So these are the modifiable risk factor. These are the one which can be changed in order to lessen their effects on developing the acute coronary syndrome. In case of the non-ST elevation MI, the coronary arteries are occluded, but they are not completely occluded. They are partially occluded. It actually differentiates this thing from the ST elevation MI, where there is a complete occlusion of the coronary arteries. So in cases of the non-ST elevation MI, or as I told, it was known as the past as the subendocardial MI, coronary arteries are partially occluded. So there are three coronary arteries: one right coronary artery, and then the left main stem, which subdivides into the left circumflex artery and the left anterior descending artery. Right coronary artery, it supplies inferior wall, it supplies right atrium, it supplies right ventricle, and it has got two sub branches. One is posterior descending artery and one is right marginal. In 60% of the cases, it also supplies SA node and is known as the dominant coronary artery. Left main stem divides into left circumflex. The name implies that it takes an acute turn on the lateral side. This left circumflex artery supplies lateral wall of the heart, and 40% of the time it becomes the dominant when it supplies SA node, i.e. sinoatrial node. And the left anterior descending branch of the left main stem actually supplies major part of the anterior left ventricle. So these are the three coronary arteries, and they supply three main walls of the heart. There are three main walls of the heart. Heart is placed in the chest like fist. It has got inferior wall which rests on the diaphragm. It has got a lateral wall, and it has got a anterior wall. These are the three main walls of the heart. There is a very narrow portion of the posterior wall, but these are the main three walls. Now on the ECG paper, as we know that ECG stands for electrocardiography. This is the electrical representation of the waves of depolarization and repolarization in the muscles. These muscles make up the walls of the heart. So there are three set of the coronary ECG leads which actually represents these three major walls on a piece of paper. Lead 1 and AVL, they are known as the lateral leads because they are mainly watching the lateral wall. These are known as the contagious leads. Lead 2, 3 and AVF, they are watching the inferior wall. They are the inferior walls, and these three are the contagious leads. Lead V1 to V6, they are located. They are the chest leads, and they are actually representing the anterior wall. And they are the 6 contagious leads watching the anterior wall of the heart. When we talk about the chest leads, V1 and V2, they are located towards the right side of the left ventricle, very near to the septum, so we call them the anteroseptal leads. Lead V3 and V4, they are located right in front of the left ventricle, and they are known as pure anterior wall. And the lead V5 and V6, they are located towards the lateral side of the left ventricle, so they are known as anterolateral. So we have got three set of the contagious leads. The word contagious is very important because this will help us managing the patient or diagnosing the patient when there will be a talk about the ECG findings of these acute coronary syndrome patient. So lead 1 and AVL, lateral wall, lead 2, 3, AVF, inferior wall, lead V1 to V6, anterior wall, and these three sets of the leads represent three different walls, and 1 and AVL are contagious, 2, 3 AVF are contagious in their own position, and V1 is contagious with the V2, V3, V4, V5, V6, and every one of these are contagious in their own respective set of the leads. So what happens when these patients present to the emergency department? These patients present to the emergency department with a certain set of the complaints or the presenting complaints of the patient of the acute coronary syndrome would be, they'll be complaining of the chest pain. This pain would be mostly on the left side of the chest, and it will be radiating towards the jaw or the left arm. This pain may be associated with the sweating or would be associated with the nausea and vomiting. There can also be a complaint of pain in the epigastric region, and patient may be nauseous. Now there are some atypical presentation of these patients, especially the atypical presentation happens in cases of the diabetic, female patients and elderly patients. These atypical presentations they can complain of shortness of breath, they can complain of only irritability or restlessness, which we very famously in Pakistan call ghabrahat. There can be a complaint of only nausea and vomiting. There can be a complaint of extreme sudden weakness in elderly patient. So if any patient presenting with these complaints comes to the ER and you come across the patient and you know that patient has got certain risk factor, then always try to assess the patient from acute coronary syndrome point of view. Always get the ECG. ECG can be normal in 25% of the patient. Be very suspicious of the heart problem if you feel it, because sometimes these are the atypical presentation, and sometimes this is the normal ECG, which makes the real problem and the challenge to the doctor who's treating the patient. Try to retain these kind of a patient and keep them monitoring for certain hours. So normally when these patients present in the ER and they have got an ECG, there are certain changes in the ECG which actually represent cardiac ischemia or acute coronary syndrome. These changes can be T-wave inversions and ST depression. When we call the non-ST elevation MI, it rules out that there will be no ST elevation in the ECG, because that is a very separate topic will be discussed later on. So these patients will have either T-wave inversions, symmetrical T-wave inversions, or they will be having ST depression. That T-wave inversions or ST depression would be in the contagious lead. For example, if that T-wave inversion or ST depression is present in lead 1 and AVL, we will call it lateral wall ischemia. Still, I'm using the word ischemia because up till now we haven't got the cardiac enzyme, which will make the difference between the unstable angina and non-ST elevation MI. So up till this point, it is cardiac ischemia. If the change of T-wave inversions and ST depression is present in lead 2, 3, AVF, either of the two, a change in the single contagious lead will not be that important, but at least two of the contagious leads should have this change. Then we will call it inferior wall ischemia. And there can be change in V1, V2, V3, V4, V5, V6, T-wave inversions or ST depression, at least in the two of the contagious leads representing the anterior wall. Then we will call it anterior wall ischemia. Now, once you have obtained the ECG and you know there are changes in the ECG, then we are sure about one thing, that patient is having acute coronary syndrome. It can be unstable angina or it can be non-ST elevation MI. So we send the cardiac enzyme at 0 and 6 hours. What are the cardiac enzymes? These are the cardiac troponins, including troponin I and troponin T. Troponin I is very cardiac specific. Troponin T is not that cardiac specific, and it falsely become positive in cases of pregnancy, surgery, trauma, chronic kidney disease, or any sepsis, DIC. So in those cases, better to send trop I. And other cardiac enzyme are CKMB, creatine kinase MB segment. So this is also a very cardiac specific, but these cardiac enzymes, they turn positive in 6 hours. So better to send a set of cardiac enzyme at 0 hours and at 6 hours. Why at the 0 hours? Because most of these patients are diabetic. They may be having a chest pain or cardiac issue for certain hours, but because of the diabetic neuropathy, they may not be feeling the pain. So it is always to be suspicious that it may be a problem which may be going on for some hours. So always send at 0 hours and then repeat it in 6 hours. If cardiac enzyme they turn out to be positive, we will call it non-ST elevation MI. But if the cardiac enzyme are negative, it will be known as unstable angina. And these both unstable angina and non-ST elevation MI are obviously a part of a same acute coronary syndrome, where we think that there something is wrong with the coronary arteries. There is some thrombus, there is some occlusion at a specific coronary artery, which is causing this problem of the chest pain and these symptoms and these ECG changes. Now, if we try to look at this ECG, the one on the very top is a normal ECG. It has got an isoelectric line, and J point is the junctional point, which is at the position of where S actually is joining the isoelectric line. This is known as the J point. In cases of the ST depression, this J point comes down and also drags with it the S and the T waves. So in normal we see T wave is upright, but in cases of the acute coronary syndrome, in both non-ST elevation MI and unstable angina, this T wave, it can be either inverted, it can be deflected negatively, but it has got a negative deflection in symmetry. The descending and ascending portion of the downward deflection of the T wave, they are equal, and this is known as T wave inversion. If a patient comes with a chest pain and has got the T wave inversions, then this patient is having acute coronary syndrome. The second finding can be there can be an ST depression where a J point or the junctional point, it draws both the S and the T towards the downside of the isoelectric line, and this is known as ST depression. So whenever a patient comes with a chest pain and we get the ECG, we should try to find out T wave inversions or ST depression in at least two of the contagious leads in three sets of the ECG leads. One and AVL lateral lead, 2-3 AVF inferior leads, V1 to V6 anterior leads. At least two of these leads should have this change to qualify for acute coronary syndrome. For example, lead 1 and AVL both should have this either T wave inversions or ST depression. And in cases of lead 2, 3 and AVF, either of the two of these three should have this change. And in cases of the V1 to V6, at least two of these 6 contagious leads should have T wave inversions or ST depression to qualify for acute coronary syndrome. Now this is ST depression in the anterior chest leads V2, V3, V4, V5 and V6. ST segment is actually going down, going lower than the isoelectric line. The J point, the junctional point, the point which connects S wave with the isoelectric line before the T wave, it is coming down. It is also bringing with it the T wave and trying to get pull on the S wave. So this is known as the ST depression because it's located in the contagious leads of the anterior set of the leads. So this is anterior wall ischemia. As long as you haven't obtained the cardiac enzyme, you'll keep on calling either the acute coronary syndrome or cardiac ischemia. But once you have obtained the cardiac enzyme, if they turn out to be positive, we call them non-ST elevation MI or the subendocardial MI. It was used to be called in the past subendocardial MI. But if these are negative, these are known as the unstable angina. So now once based on the clinical presentation, history and ECG finding, we have diagnosed that this is actually a case of acute coronary syndrome, which can either be unstable angina or non-ST elevation MI, then we will start treating the patient. The management of both the unstable angina and non-ST elevation MI is same. So we are now waiting for the cardiac enzyme to come, but we have started outrightly the management of the acute coronary syndrome, taking in view that this either can be the non-ST elevation MI or unstable angina. We have got two plans to treat these patients. Plan A is basically the pharmacological management, and we think that the hospital which is actually receiving these kind of patients haven't got any catheterization facilities, so we start treatment with drugs. That plan actually can be remembered with the mnemonic MONA/B, MONA/B, where M stands for morphine. Morphine is an opioid analgesic. Injection morphine has got a strength of 5 milligram. It is given to relieve the chest pain and anxiety. It can be given in the incremental doses of the 2.5 milligram each time with a spacing of 5 to 10 minutes. But because it has got a propensity to cause hypotension or respiratory depression, so one needs to be very watchful regarding the blood pressure and the respiratory effort of the patient. So morphine is given to relieve the chest pain and anxiety. In the mnemonic, second thing is O. As long as the patient's saturation stays more than 94, we do not need to give oxygen. But if patient's saturation, which is the percentage of the hemoglobin saturated with oxygen, is less than 94, we should give oxygen through the nasal cannula to maintain it above 94%. The third thing is N. N stands for nitrates. Nitrates are vasodilator. They cause the vasodilatation of the coronary arteries, which helps to increase the supply of the blood to the dying or the muscles of the heart which are endangered actually. They can die. So we give the nitrates. Here in Pakistan we have tablet Angicid, which is a glyceryl trinitrate. We give 0.5 milligrams sublingual and we can repeat it 3 times. And along with, we can also give injection nitroglycerin, which is nitronol. This is 1 milligram per ml. We can start it in Inferior, and it also relieves the chest pain, because when the supply of the blood to the heart is increased, then there are chances that the chest pain would settle down. There is another option of isosorbide dinitrate, which we here use with the name of Isokit. It's a 10 milligram injection which we dilute in 100 ml normal saline, and we can start its infusion. Now keep one thing in mind: nitrates in cases of the right-sided heart ischemia, in those cases where there are changes in the 2, 3 and AVF, where right coronary artery has got problem, they can cause a rapid fall in the blood pressure. So nitrates are either avoided or used very cautiously in those patients who are presenting with any changes in the ECG regarding the right side of the heart. Because if we give nitrates to these patients, they will affect the preload, because it affects both the preload. It can cause the vasodilatation of the veins, not only the arteries. So that can drop the blood supply towards the right side of the heart, and this way blood pressure can be compromised. So nitrates are given very cautiously in those patients in which there are changes in lead 2, 3 and AVF or V1 and V2. So that is again a whole topic to discuss. The third thing in the MONA B mnemonic comes the A. A is one of the very, very important part. A has 2 components. One is antiplatelets and one is antithrombotic. Antiplatelets, we have got 2 types of the antiplatelets. One is Disprin. We give tablet Disprin, 300 milligram, non-enteric coated. We ask the patient to chew it. We don't ask him to swallow it, because we want its instant reabsorption in the body, so that the process of platelet clumping should be arrested. So we give 300 milligram Disprin. We ask the patient to chew it. Along with this Disprin, we also give Clopidogrel, which can be available with the name of Plavix, Noclode, Loplate, and this is given. It's a tablet of 75 milligram. We give 4 tablets stat with a sip of water. We don't ask the patient to chew it. We just ask him to swallow it with the water. So one thing is antiplatelets, and the second component of the A is antithrombotic. In antithrombotic, we have 2 options. Either we can go for the cheaper one of the unfractionated heparin. We give 5,000 international unit IV stat, and then we start an infusion of 1,000 unit per hour. And we can monitor the effectiveness of heparin using the activated partial thromboplastin time. We should keep it 2 times the normal. The normal value of the APTT is 35. We are to keep it within the range of 50 to 70, and this way we think our heparin is working as an antithrombotic. So the second option can be a little bit expensive, but it is very easy to use. This is the low molecular weight heparin. Low molecular weight heparin is enoxaparin, and here in Pakistan we have with the name of Clexane. This is given subcutaneously in a dose of 1 milligram per kilogram BD mostly in an adult, this is given 60 milligrams subcutaneous BD, because if it has its effect in the factor 10, so we do not need a routine lab monitoring. So we can use either of the two. In the mnemonic of the MONA B, the slash component is B. That is optional. If a patient has got a heart rate of 100, more than 100, then there are chances that because the demand and the supply chain is compromised, so we need to decrease the demand. If a patient is having acute coronary syndrome and is tachycardic at the same time, then he is having higher demands against a compromised supply of the heart. So we need to bring down the heart rate less than 100. In order for that target to be achieved, we use the metoprolol, which is a beta blocker. It should be avoided in bronchospasm cases like asthma and COPD, and in cases of the bradycardia, because obviously it works to lower the heart rate. So if heart rate is more than 100, we give metoprolol, which comes here with the name of injection low pressure. 5 milligram we give in the incremental doses of 2.5 milligram each time. And when our target heart rate is reached, when the heart rate is less than 100, then we switch these patients to the oral form of the metoprolol. We can give tablet Merol, which is 100 milligram. We can give quarter dose 6 hourly to keep the heart rate well within the range of 60 to 90 beats per minute preferably. So this Plan A is the pharmacological management. There are many hospitals which have catheterization facility. For example, in government hospital in Lahore, we have PIC, a very famous government hospital which is cardiac specific. They have these facility. In the private setups, we have Doctors Hospital which provides the catheterization, and so many other hospitals. So if a patient presents in an ER of a hospital with chest pain, has got T wave inversions and ST depression, and doctor suspects that this patient is having acute coronary syndrome, then the offer can be given that patient will have the catheterization or the angiography. Literally, angio mean blood vessel and graphy mean picture. You take the patient to the catheterization lab, you access the coronary vasculature through the either radial artery or femoral artery, you give contrast. So there should be no contraindication to the contrast, or there should be relatively less compromised renal functions, where you can use the non-ionic contrast. You give the contrast, you actually take the pictures of the coronary arteries that tells you which coronary artery has got the thrombus. It can be right coronary artery, it can be left circumflex artery, it can be left anterior descending. If the three of the coronary arteries are compromised, this is known as the triple vessel disease. Or if there is anatomy of the coronary arteries such that you cannot actually maneuver it, you cannot actually manipulate it further, then in these two cases, we advise the patient to go for the coronary artery bypass grafting, very famously known as the bypass operation. So CABG is performed in those cases where either there is a generalized thrombus formation in all of the three coronary arteries, or the coronary arteries have got a very difficult to engage anatomy. But if there is only one coronary arteries is involved, or there are two minor coronary arteries, they have a thrombus, then the option can be given of angioplasty. Angio mean blood vessel and plasty mean repair. The same route can be used to dislodge the thrombus and suck it out. This would be known as the repair of the coronary arteries, called angioplasty. Because there is a risk of reocclusion of the coronary arteries, so stent placement is also done. This process of doing the angiography plus angioplasty is known as PCI, Percutaneous Coronary Intervention. So those hospitals which have a facility of catheterization, they can give this offer to the patient, and instead of only medically managing the patient can be shifted to their cath lab, angiography can be performed, and based on the finding of the angiography, then procedure of angioplasty plus stenting or CABG can be advised and proceeded further. Now say if patient hasn't got that level of the treatment, patient belongs to some village and is not able to make it to the hospital within a certain time, or then in order to assess damage to the muscle of the heart, we can actually do echocardiogram. Echocardiogram actually helps us to tell us that this heart attack, this acute coronary syndrome, has damaged which walls of the heart. There can be hypokinesia, there can be akinesia, there can be dyskinesia of specific wall. For example, if there was a thrombus in the right coronary artery, there are chances that on the echocardiogram we will have a decreased or absent hypo or akinetic movements of the inferior wall. And if the thrombus was in the LAD, left anterior descending, then there are chances that the hypokinesia or akinesia or dyskinesia can be in the anterior wall. And the same goes with the left circumflex and the lateral wall. But we have another thing actually which can be on the ECG, that by looking at the ECG of the patient, we can say that this patient had MI in the past, but that is again a very separate topic and should be discussed at some other time.